This program is brought to you by Stanford on iTunes U at Stanford University. Please visit us at itunes.stanford.edu.
Thank you very much. It's a real pleasure to be here. Now, prostate cancer is a very common disease. In 2003, it was estimated 220,000. This year, estimated 250,000 men will be diagnosed with prostate cancer, making it the most common malignancy in American men. At that time, 28,900 deaths. This year, estimated approximately 30,000 deaths, making it the second leading cause of cancer death in men. And if you look, the numbers look very similar for breast cancer. I could take out prostate and put in the word breast. It looks exactly the same for women. It's a leading cancer in women and a leading killer in women. In many ways, these two diseases are cousins. So it's an extremely common problem in men, approximately a 16% chance in a man's lifetime that he will be diagnosed with prostate cancer. What are the risks for getting prostate cancer? Age, race, family history, I'll talk about. Those are non-modifiable risk factors. We can't really pick our family, and unfortunately, age is inevitable. And also diet, which might be a modifiable risk factor, and I'll talk about that briefly. Let's talk first about age. You know, it's quite interesting. You can see, as with most malignancies, the risk of prostate cancer goes up as one gets older. What's interesting about prostate cancer is highlighted in this graph, this particular graph, though. If you look on the y-axis, it says the histologic prevalence. What this is a series of men who have died of other causes. And the pathologists have gone back and looked in their prostates to look to see who has prostate cancer. And you can see in men in their 40s, up to 30% of men in their 40s, 20 to 30% will have some cancer in their prostate gland. And that number goes up with each ensuing decade. Now, if you look at men who actually come in and are clinically diagnosed with prostate cancer, that is, I as a doctor find them, examine them, they have an elevated PSA, do a biopsy and find cancer, and those are cancers we treat. It's about 1% of men who have prostate cancer in their 40s, and then those numbers go up up through men in their 60s, 70s, and 80s. So there is an increasing risk with age, but there is a lot of cancer, prostate cancer, that's out there in men that they don't realize they have it. So many men have prostate cancer. It manifests itself clinically, that is, as a disease that I find in the clinic that we have to treat in about 16% of men in their total lifetimes. So many men have it that they don't know about, but many men still will get it, that it does become manifest and need treatment. And that's going to be important later when we're talking about how to treat this disease. Now, the other thing that's happening with age and prostate cancer is that the average age that men are diagnosed with prostate cancer is going down. And the reason for that is right around 1987, really picking up in about 1990, we began to screen intensively with prostate-specific antigen, which is a protein that floats around the bloodstream, first described for use clinically by Tom Stamey here at Stanford University. And when you use PSA, you see what happens to the mean age of men who are diagnosed with prostate cancer. It is estimated that use of PSA screening will push back the time of diagnosis of prostate cancer by approximately 5 years. So you buy 5 years earlier diagnosis with PSA screening. I'm going to talk a little bit more about that later. So what that translates into is that we're finding prostate cancer in younger and younger men of all races. Let's talk about race for a moment. This particular graph just shows the rate of prostate cancer diagnosis per 100,000 men. And you notice, compared to other cancers, prostate cancer is at the very top, as I mentioned at the beginning of this talk. In Caucasian men, prostate cancer is the most common, followed by lung cancer, colon cancer, bladder cancer, and so on. It's very common. So too in African Americans. And in fact, if you look, the rate of diagnosis is in fact much higher in African American men than whites. So too with death rates. So prostate cancer is very common in African Americans, and more African American men die of prostate cancer. Now, what does that due to? There is a lot of argument about what that's due to. The simplistic answer is that it has to do with genetics, but it's much more complicated than that, and something that people are debating ferociously. Part of it has to do with access to health care, socioeconomic status, diet differences, the tendency for men to get screened for cancer, to actually seek care, and so on and so forth. So it's a very complicated issue. Genetics does play some role, though. We do know that. If you look at men in blacks in Jamaica, for instance, their rates of prostate cancer are extraordinarily high and matching that of African American men. If you look at hereditary prostate cancer or genetic forms of prostate cancer, there tends to be a saturation or enrichment in those populations of men who probably have the genetic disease for African Americans. So again, it looks like there is a genetic component to this, but it's not exclusively that. This is a complicated disease in which both environmental and genetic factors can interplay here to increase one's risk of the disease. What about genetics? Prostate cancer can run in families, no doubt about it. If a man has a family member, a first-degree relative, let's say a father who has prostate cancer, their risk of prostate cancer is higher, about twofold higher than the general population. If it just so happens that that man's father had prostate cancer diagnosed at a young age, say 50, the risk is much higher. Here it's listed as sevenfold. The studies debate about it, whether it's fourfold, sevenfold, but it is much higher. So an early onset of the disease signals probably a genetic component, particularly if your relative had it at a young age, your risk is much higher. This is true of breast cancer and other hereditary forms of cancer too. They tend to show up a little bit earlier. And people who have it, who have hereditary forms, their relatives are at risk for it. For instance, one study showed that if a man has two first-degree relatives, that is, let's say a brother and a father who have prostate cancer, their risk goes up fairly dramatically, anywhere between 7- and 9-fold. Here listed 5- to 8-fold, depending on the study again. Now, diet has been linked to a risk of getting prostate cancer. Fat is the one thing that's fallen out of many studies, animal fats in particular, with an association with an increased risk of prostate cancer. And by animal fats, I mean usually red meats. Dairy products also have been associated with an increased risk. So any type of animal fat has been linked to a higher rate, usually 2 to 2.5-fold higher chance of getting prostate cancer. On the flip side, there are some dietary things that some epidemiological studies, that is, studies looking at big populations of men, have shown an inverse risk of getting prostate cancer. For instance, there are a couple studies that came out just a couple years ago showing that men who eat a lot of cruciferous vegetables, things like broccoli, bok choy, Brussels sprouts, have a 2-fold lower risk of getting prostate cancer. My laboratory has worked on this particular question and found that a component in cruciferous vegetable called sulforaphane is probably responsible for the cancer preventative effect of these vegetables. And in fact, it's due to the fact that this compound is particularly good at turning on enzymes that defend against cancer-causing toxins in the body. Red wine recently has been, I love this actually, red wine has recently been linked, there's a paper that just came out this month to a lower risk, about a 2-fold lower risk of getting prostate cancer. Intriguingly enough, it looks like it's only red wine, not white wine, not other forms of alcohol, in contrast with what people have seen in cardiovascular disease. Now the reason for that is not at all clear. I actually knew about this result a couple years ago from a collaborator up at University of Washington in Seattle. And we started looking at this question in the laboratory. There is a compound that's found almost exclusively in red wine called resveratrol. We've done some basic work that indicates that resveratrol does a couple things. First of all, it stops the cancer cells from growing and dividing. The second thing is that it actually blocks male hormone in the prostate cancer cells. And remember, male hormone, testosterone, is what can make prostate cancer cells grow. So it's an intriguing finding. It has a lot more work to go, but at the very least, this is another thing people have linked to a lower risk of prostate cancer. Same too with soy and a few other things that we'll talk about in just a few minutes. So now with that in mind, one thing I just want to highlight on fat, just to give you an example of one of the studies relating fat to risk of prostate cancer. Very simplistic study. If you just plot out on a graph the risk of, or the actual rates of death from prostate cancer and the actual amount of dietary fat people consume, you find a very, very high correlation. I think no statistician in the world would have a trouble drawing a line through this and giving you a probability. It's very clear that increased fat intake is associated with an increased risk of prostate cancer. Now, does that necessarily mean cause and effect? Not necessarily. It's going to take a lot of work to prove that at a basic level. But again, it's one of these strong, strong associations between the environment and prostate cancer risk that have been found out there. Now, the degree to which the environment, and diet in particular, contributes to prostate cancer is still highly debated. And I've seen estimates anywhere between 10 to 20% of prostate cancer is attributed to diet, as high as 75% of prostate cancer can be attributed to diet. A lot more work is going to be necessary, but at the very least, it can modify your risk to some degree. Now, let's segue quickly into what this evidence could tell us about preventing the disease. Remember, a few moments ago, I told you that prostate cancer depends on the male hormone to grow. We've known that since about the 1940s, when a man named Charles Huggins found that by castrating men, removing male hormone testosterone, prostate cancers can shrink away. A large clinical trial was established called the Prostate Cancer Prevention Trial. Started in the early 1990s, and they used a drug called finasteride, which maybe some of you have heard of, also called Proscar. It's a drug that helps shrink the prostate gland by, in effect, blocking male hormone to some extent in the prostate. They enrolled 18,000 men and randomly assigned them to either get a sugar pill or finasteride, treated them for 7 years, and many, many men at the end of this study received a biopsy to see who had cancer and who didn't. What they found was that finasteride, in fact, did prevent prostate cancer. If you look at the graph, the men on finasteride, if you actually do the numbers out, there's about a 25% lower risk of them getting prostate cancer. In terms of absolute risk, at the end of the study, about 25% of the men on placebo had prostate cancer, and about 18% of the men on finasteride had prostate cancer. So about a 25% reduction in risk. Now, this study has generated a lot of controversy because one of the other findings of the study, which people are still trying to work out, is that despite the fact that there were lower rates of prostate cancer, it looked like the absolute number of men who had high-grade disease, and high-grade disease is what we worry about as clinicians, was increased in the group on finasteride. That's clouded the whole study. So people are debating now, at the very least, it has tempered our enthusiasm for using finasteride for prevention. If the men on finasteride have more high-grade disease, that's the more aggressive forms of prostate cancer. So that's led to us not recommending it wholesale for prevention of prostate cancer. And there are many reasons why that might be the case. It could be that the drug just changes the appearance of the cancer to make it look worse than it actually is. A lot of work in the next few years is going to work this out. Regardless, we haven't put all our eggs in one basket. There are other tantalizing leads to prostate cancer prevention that are now being pursued in other means. I mentioned some of them earlier. Another intriguing finding that came out actually from a trial trying to prevent lung cancer. And what they did was randomize patients. So patients were randomly assigned to either receive vitamin E, beta-carotene, a combination of the two, or a sugar pill. Now, there had been a whole bunch of data that showed in populations of men, the ones that had a lot of vitamin E and or beta-carotene floating around their bloodstream had a much lower risk of getting lung cancer. So the thought when they designed this trial is, we can't lose. Either it's going to show a protective effect, or at the very least, it's not going to show any harm. Well, the fallout was, at the end of this clinical trial, they had to end it early because the men who received beta-carotene had an increased risk of getting lung cancer. It was a total disaster, but very interesting. It shows you that, it shows the one potential thing is that a supplement doesn't match food. The beta-carotene that they measured in all these other epidemiological studies that were floating around in people's bloodstreams reflected the fact that they ate a lot of vegetables. That's where beta-carotene comes from. So what that probably means that eating a lot of vegetables is a good thing, but just taking the one component you think is the good thing may not necessarily be the right way to go. Now that being said, that's a little sidetrack that I always find fascinating. That being said, in this trial, at the very end of it, they did look at other cancers. This is what's called looking at secondary endpoints. This trial was just designed to look at lung cancer, but they did look at other cancers, and what they found was interesting. The men who received beta-carotene didn't really affect their rates of prostate cancer, but the ones who got vitamin E had about a 1/3 lower rate of getting prostate cancer, and actually about the same effect, lower death rate from prostate cancer. Now that doesn't necessarily mean that vitamin E prevents prostate cancer, because remember what I told you before, this is designed to look at lung cancer. So it could be that the people who were enrolled to get the sugar pill, the placebo, for whatever reason were higher risk for having prostate cancer or already had it or something like that. So it doesn't definitively answer the question, but boy, is it tantalizing. A related phenomenon happened with selenium. There was a whole bunch of data that suggested that selenium prevented different types of cancer, in particular skin cancer. So a man named Larry Clark designed a trial looking at trying to prevent skin cancer in 1,300 men and women at risk for skin cancer in Arizona. That is, they'd already had some skin cancer, and they tried to prevent a secondary recurrence. At the end of the study, no difference whether they got a sugar pill, a placebo, versus getting selenium. But the men who had gotten selenium had a 2/3 lower rate of having prostate cancer. So again, a fairly dramatic finding. Unclear what it means. Again, it's not designed to look at prostate cancer, but very, very tantalizing. Around that time, my laboratory actually looked at men who we measured selenium levels in their bloodstream and looked at their risk of later getting prostate cancer. So 5 years later, we took a look at the men who we'd measured their selenium levels in their bloodstream, and lo and behold, the men with the lowest levels of selenium in their bloodstream had a 4- to 5-fold higher risk of getting prostate cancer 5 years later. So selenium might look protective. Now, I'm going to a little footnote here. Probably in the Bay Area, we don't have to worry so much about this because there's a lot of selenium in the soil around here and in the Central Valley where a lot of our fruit and vegetables and even meats come from. So we probably get enough selenium here. But the people at risk, and the study that I done was on men in the southeastern United States where there's very low levels of soil selenium. But at the very least, these findings in vitamin E and selenium have again fueled a big clinical trial that's called SELECT. 32,000 men this time. It's a huge study costing tens of millions of dollars, sponsored by the National Institutes of Health in this country. Again, it's a very similar study, 7 years of treatment. They were hoping to enroll all their patients in about 3 to 4 years. In fact, they enrolled patients in less than 2 years because there was so much enthusiasm for this clinical trial on the part of study subjects. So we already have filled out this trial, and we will find out in 7 years whether selenium and vitamin E actually prevent prostate cancer. Now let's change gears a little bit and talk about how we see and treat prostate cancer in the clinic. How do we diagnose prostate cancer? How do we find it? The mainstay for finding prostate cancer, screening for prostate cancer, historically a digital rectal examination, that is your physician feeling your prostate gland. That's the way it's been found for the last 100 years. Prostate-specific antigen, or PSA, I mentioned earlier, was described in the mid to late 1980s by Tom Stamey here at Stanford, and really now is a workhorse for how we screen men for prostate cancer. But again, those are all hints that men may have prostate cancer. The definitive way is to actually go get a piece of the prostate by prostate needle biopsy. I'm going to talk about each one of these in turn. First, let's talk about digital rectal examination and PSA together. We use them in concert. You really need to do both of them. Again, if you look at the risk of having prostate cancer, for a man who has a firm nodule or some abnormality on their prostate, that's the DRE positive on this graph, and an elevated PSA, defined as a PSA above 4, the risk of finding prostate cancer is almost 50%. So if you have both of those findings, you have a fairly high chance of having prostate cancer. If, on the other hand, you have a normal rectal examination, so your doctor tells you your prostate feels normal, but your PSA is elevated, The risk is somewhere around 25% in many, many studies. On the other hand, if you come in just with the digital rectal examination being abnormal, your chance is roughly about 25%. But if you factor out men who have a low PSA, the risk of prostate cancer is much lower, closer to 10%. This is data from about 1994. It's crept a little bit, but just bear in mind that there are some men who have a very, very low PSA, but an abnormal finding on rectal examination, they should still be biopsied. So you need to use the two, the digital rectal examination and the PSA together. In fact, during my time at Johns Hopkins, about 25% of the patients we were operating on there had a normal PSA at the time of surgery, that their tumors were just found because of an abnormal rectal examination. Now, nowadays, probably about 80% of patients that we diagnose with prostate cancer have a normal rectal examination, and it was their cancer was found just because they had an abnormal PSA. What has this type of screening done in terms of how men present with prostate cancer? Digital rectal examination is shown in the bars in red. This is actually a snapshot in 1994. If you took this same snapshot in the mid-1980s, before PSA came along, what it would show you is that approximately 50% of the patients who walked into a doctor's office with an abnormal rectal examination who had prostate cancer, the cancer had already left the prostate gland. They already had cancer outside the prostate gland, about half of patients in the mid-1980s. Along comes PSA, and remember what PSA does. PSA pushes back the time of diagnosis approximately 5 years. What has happened with that is if you look at the far right of this graph, the number of men who are detected by PSA screening goes down dramatically, that low green bar down at about 10%. And in fact, the last time I saw these numbers, a few years ago, they had the latest numbers, I think it was around 2002, the number of men presenting now to a doctor with advanced disease, that is cancer outside the prostate gland, is less than 5%. So it went from 50% down to less than 5%, largely attributable to PSA screening. So it's made a huge difference in the patients we're seeing in clinic. Now, the PSA can vary with age, and remember that first graph I show you, prostate diseases increase with age, and that's why PSA can vary with age. A young man, that is a man in his 40s, has a low probability of having enlargement of the prostate gland, what's called benign prostatic hyperplasia, which, you know, heck, 3/4 of us get if we have a prostate gland. Your prostate gland gets enlarged as you get older. That can make your PSA go up. Prostate cancer can also make your PSA go up. A man in his 40s should have a PSA less than 2.5. A man above the age of 50, let's just put all men above the age of 50. In general, I say anyone above the age of 50 should have a PSA below 4. There are a lot of ways that people use this age-specific PSA, but that's probably the most useful and productive way of using it, so you're not missing significant cancers in young men, but picking up the significant ones in older men. But that being said, you should adjust the PSA based on age. Now, okay, let's say a man comes in and has either something suspicious on rectal examination or does have an elevated PSA. How do we diagnose it? We do so with a transrectal ultrasound and biopsy. This is an ultrasound probe that goes in the rectum, just like we do a digital rectal examination. We can look at the entire prostate gland with the ultrasound probe. Now, when transrectal ultrasound was first described, and actually, again, we had a big hand in that at Stanford University in the early 1980s, people were quite enthusiastic about it because the ultrasound would show us abnormalities in the prostate. But remember what was happening in the early 1980s was before PSA screening, when men had very large tumors. Nowadays, I'll be quite honest with you, ultrasound it's quite uncommon that it shows us a tumor in the prostate gland. Why? Because PSA has pushed back the time of diagnosis so early that most men have relatively small cancers in their prostate gland. That's a good thing. We want to find them earlier. So most men, like I said, we won't see an abnormality on the digital rectal examination. Now, this diagram, all it shows is the ultrasound probe in the rectum here showing us the prostate. Here's what we're looking at on the screen here. It looks kind of fuzzy to us, but actually, to you maybe, but back here is the rectum. Here's the whole prostate gland in kind of a cross-section cut straight across it. So there's a cross-section of the prostate. Up front here is is where the prostate gets enlarged for benign prostatic hyperplasia, that is, enlargement of the prostate that we all get with aging. Only about 10, maybe 20%, but probably closer to 10% of cancers happen in this front part of the prostate gland. About 90% of prostate cancers occur in this back part of the gland right here. That actually has consequences in terms of how you design your biopsy. Now, when we do biopsies for prostate cancer, actually one of my oncology colleagues pointed this out to me a few months ago, and it really has stuck in my mind. Prostate cancer is one of the only cancers that we diagnose by a blind biopsy. We're looking at the prostate with an ultrasound, but we aren't looking at a discrete tumor when we put the needle in. What we have gone over to are these so-called systematic biopsies. In other words, we just try and cover most of the real estate. Now, the way we used to just biopsy where we saw the abnormality on ultrasound, just like we did for every other cancer. But Tom Stamey, again here at Stanford, had the insight that maybe we should just try and cover the real estate of the prostate and do 6 different biopsies, which is what he and Martha Terrace and several others described in the late 1980s. This was the workhorse, the mainstay for the way we did biopsies up until for the next 10 years. Now, when those biopsies are done, these little arrows just show where the needles go in the prostate and what tissues actually we're sampling when we do the biopsies. And it turns out we get some of this peripheral zone, the back part of the prostate where 90% of the cancers are, but we're also getting the front part of the prostate where enlargement happens, where very little cancer happens. So we probably are not optimizing which tissue we should sample. So people debated about how to better sample that. Should we direct the biopsies more to the side and get more peripheral zone? But what people have gone over to, really spearheaded by Dr. McCullough, Presti, and Slaywin, is just doing more biopsies. And with that, you can cover more real estate. And effectively, the biopsies that are out towards the edge of the prostate, the ones that are more towards the side, are the ones that are going to get more of the peripheral zone, and that's where you pick up more of the cancers. Now, remember what I told you before. Patients who come in with an elevated PSA alone, which is, remember, 80% of patients. So 80% of patients come in just with an elevated PSA. And we do a biopsy. I told you in that earlier graph from 1994, we find cancer in about 25% of them. With these more extended biopsy schemes, look at the yield now. It's about 40%. So what that means is we're picking up more cancers that we missed otherwise with the biopsy. Remember, the biopsies are more or less random, blind biopsies. So we have to do the best we can at covering the real estate in the prostate gland. And that's what these more extended biopsy schemes have done for us. We're missing fewer prostate cancers. Again, this is going to push back earlier the time that men are found with their prostate cancer. There are going to be fewer men missed, hopefully better cure rates. Now, the question is, so now we've screened the man for prostate cancer. We found the prostate cancer. The issue is now how to properly treat the prostate cancer. And this is oftentimes one of our greatest challenges, is the best way to treat prostate cancer. And the reason I say that is, remember that very first slide I showed you with the bar graph. There are many men walking around with some cancer in their prostate gland that they're going to die with rather than of. Many men have prostate cancers that are clinically insignificant. The problem is we have no great way to figure out which ones are which. We have crude ways. We have reasonable ways. I mean, the PSA level will correlate with the degree of risk. The higher the PSA, probably the more chance it's a significant prostate cancer. The pathology grade, what's called the Gleason grade, will correlate with risk. So a higher Gleason grade, the higher the risk. Whether or not we can feel something on rectal examination. That implies that it's a large enough tumor that it is of sufficient risk. Now, before we get too distraught about that, maybe there's a lot of prostate cancers we're treating that we shouldn't get treated. This is something we've worried a great deal about and have looked at quite a bit. The bottom line is the amount of cancer in the gland correlates with the risk of a man dying of the disease. The more cancer in the gland, the higher risk the disease is. Again, work from Stanford in the early to mid-1990s showed that. It turns out that most of the men we're finding on digital rectal examination in PSA, if you look in their prostates when we remove them at surgery, the vast, vast majority of them, 90% at least, have a large enough cancer that it is considered life-threatening in the long run. So the ones we're picking up clinically are not the ones that are the incidental ones that people die with. They are more than likely the ones that people will eventually die of if left untreated. That graph that showed at the very beginning, that showed, 30% prostate cancer in 40-year-olds, up to 70% in 80-year-olds, those are some abnormal cells that the pathologist might call cancer when he looks at it under the microscope, but they are teeny-weeny little spots. The ones that we're finding clinically are the larger tumors that are potentially life-threatening and probably need treatment. But that being said, there are certainly some men who come in who have prostate cancer that we find clinically that are still not going to die of their disease, and we don't have a great way to sort them out. We have, again, these crude measures, but not a perfect way. So that has to be in the back of our minds when we're counseling men for therapy. A hot area of research, I guarantee, over the next probably decade at least, is going to be coming out with ways of sorting out who has the more aggressive and who has the less aggressive tumors. My laboratory is actually shifting over almost entirely to this type of work. It's something that we've been doing over the past few years and really has a potential to make a huge impact on patients. Now let's talk about the treatments a little bit. What are the basic ways to approach it? Surveillance, watchful waiting is one way to approach prostate cancer. Remember again, there are men who have prostate cancer they're not going to die of. We have to hopefully pick those men out and pick them out appropriately and keep a close eye on them. By watchful waiting, I don't mean that we forget about men and never see them again. Keep close tabs monitoring these men and make sure that there isn't cancer that's going to get away from us. Radical prostatectomy has been a mainstay of treatment for the past 100 years, first described in about 1904 by Hugh Hampton Young. External beam radiation therapy pioneered here at Stanford in the 1960s and 1970s by Mel Bagshaw, and brachytherapy or radioactive seeds. I'm going to touch on each of these very briefly. Now let's talk about surveillance first. We've looked, several groups have looked back at men who have been managed with watchful waiting, that is, who have decided not to have surgery and just be surveyed over time. And one thing that falls out, and this is what I alluded to before, is that men who have high-grade disease, in this case labeled grade 3 on this graph, have a fairly high chance of succumbing to their disease. Whereas men with lower grades of disease are at lower risk. Their risk isn't 0, but they're at lower risk. And this is a study carried out by Jerry Chodak at the University of Chicago, pooling many studies together in the United States. There also was a study out of Scandinavia that showed for men who were detected with low-grade prostate cancer, they had the same risk of dying as men who didn't have prostate cancer. This led to huge controversy in the early 1990s. Now, there were a lot of problems with these kinds of studies, but at the very least, it does raise in the back of our minds the fact that there are some men that do perfectly well with surveillance. There is a problem, though. Many of these studies have a huge selection bias, and by that I mean they have older patients in them, so men who are, in the Scandinavian study, average age of 72, who are at risk for dying of other things like heart disease. Most of them had small cancers. Most of them had low-grade cancers. So sure, we're going to expect that they have good outcomes and hope that their survival rates match the general population. We've learned a couple things since the early 1990s. One of the most dramatic is, and this is to immense credit to the group in Scandinavia who reported this. When they reported their follow-up data at 15 years, Pat Walsh and I wrote an editorial in the Journal of the American Medical Association criticizing that study. If watching and waiting is such a good thing to do with prostate cancer, why are death rates so extraordinarily high in Scandinavia? They're higher than they are in the United States. So if watching and waiting is a good thing, why are so many men dying of the disease? It turns out there are a couple things that we've learned since then. The first thing is this. To their credit, they looked at their men after 15 years, and even in men with very low volume, that is a small amount of very low-grade disease, after 15 years, a vast majority of them ended up dying of prostate cancer. So if you follow men long enough, and if a man lives long enough, they have a good chance of succumbing to the disease. But remember what I said, that's after 15 years. So when we're thinking about treating men, they should have probably a 10 to 15-year survival rate from other causes, heart disease and other things, before we think about treating them. The second thing we learned, and this is to the immense credit of the Scandinavians, is that they actually did a randomized trial. So what they did was, men came in with localized prostate cancer, like we diagnose in our clinic, and they flipped a coin. Heads, they went on watchful waiting. tails, they had surgery. Okay, now that study is hard to do. Not many men want to sign up for it, but they got 700 men in several Scandinavian countries to sign up for it. Now this is a very, very busy slide, and the only takeaway message of this slide is that if you look, the men were extremely well matched. It's not that the watchful waiting group all had low-grade disease and the surgery group had high-grade disease. They were very, very well matched. So the same number of men had high-stage disease as low-stage disease in the watchful waiting surgery group. Same number of men had high-grade and low-grade disease in the groups. Similar PSAs across the groups. So they were very, very well matched. This was a good trial. What they found really, I have to be honest, surprised me. If you look at 5 years, there's really not much difference in survival rate. Now, this is the chance of dying of prostate cancer. By the time they looked at 8 years, the men who had surgery had a 50% lower chance of dying of prostate cancer by 8 years. Now, I thought they would have to wait 15 years to see this difference. They saw it by 8 years. Now, the absolute reduction was 7%, so 13% chance of dying of prostate cancer, close to 14% versus 7%. But that's a fairly dramatic result by 7 years. And once again, this affects on how we counsel men with regard to watchful waiting. The second thing that they found is if you look at the risk of cancer spreading to the bone, that is metastatic disease, again, reduced by about 50% by 8 years. Men who develop metastatic disease have a very, very high probability that they are going to succumb to their disease. So I'm anticipating that as this study goes on, more and more, you're going to see a bigger difference in the number of men dying of prostate cancer between the watchful waiting and surgery group. A few words about radical prostatectomy. Radical prostatectomy, I mentioned, has been the mainstay of treatment. It was originally described 100 years ago, actually done between the legs, what's called a perineal prostatectomy. Not many of us do it that way anymore. Pat Walsh at Johns Hopkins described doing it from the front and came up with such innovations as the nerve-sparing procedure and so on. That is, ways to do the cancer to minimize the side effects that men face after having the operation. And that led to a whole change in the way we do the operation. Most of us do it through an incision from the belly button to the pubic bone. It's about a three-hour operation. Men are in the hospital for 2 or 3 days and do very, very well afterwards. The critical things when doing this operation, this is a cartoon just trying to depict the prostate in black. There are 2 nerve bundles that run alongside the prostate gland. Those are depicted in yellow. Those are really not visible to the naked eye, and this is the tremendous credit that Pat Walsh deserves in discovering those nerve bundles. Before Pat Walsh came along, people thought that the nerves responsible for potency, a man's ability to get an erection, ran right through the middle of the prostate gland. And at that time, in about the 1970s up to 1981, when he first made his important discovery, men were just counseled that if you have your prostate out, you're going to be impotent 100% of the time. He'd made some changes to the operation in which he had a couple men come back telling him that they were able to get erections. And that led him to do some very basic anatomical studies, and he found these nerves. Now, you'd think anatomy, how we're put together and things like that, was something figured out back in the Renaissance. But here Pat Walsh in 1981 made this discovery of where the nerves are responsible for erections and modified the operation to figure out how to save those nerves and spare men's potency. And with that, like I said, it used to be almost 100% of men were impotent. Now about somewhere, depending on the man, anywhere between 10 and maybe up to 50%, depending on the age and the potency status of the man before he walks in the operation. Anywhere between 10 and 50% of men are impotent, and anywhere between 50 and 90% of men are potent afterwards. For young men, men in their 40s, 80 to 90% of them are potent. For men in their 60s, it's more like 1/3 are impotent, 2/3 are potent. That is, 2/3 are still retaining their erections. This was a huge change in how we treated patients. The second thing that's important in doing this operation is the sphincter muscle, depicted by in a very cartoonish fashion by the bar in green. This is a muscle that surrounds the urethra, responsible for holding the urine in. Our techniques have really progressed fairly dramatically over the past 20 years, so we do a much better job, whereas almost 1/3 or more men used to be incontinent. Now it's down around 5 to 10%. So 95% of men are retaining their urinary control after the operation. Now, there have been some new innovations. Laparoscopic prostatectomy is something that was described in the late 1990s, about 1998, were the very first cases done. More and more people are exploring doing the operation this way. This is done through little keyhole surgery, so little holes in the belly button and in the abdominal wall. Tom Hsu here at Stanford is doing quite a few of these. And that has the advantage of eliminating the need for the incision from the belly button to the pubic bone. Also potentially less blood loss. It's a procedure somewhat in evolution. Right now I can't guarantee you that the potency rates are matching the open operation, but it is a very interesting way to approach the operation. The other potential benefit is slightly better recovery, but actually some studies are questioning whether that is the case. You'd think it would be better with these small keyhole incisions, but that low incision in the lower part of the tummy is so well tolerated that most men bounce back fairly quickly from that. But that being said, this is an approach that many people are looking back. It's interesting. I think it still should be regarded as somewhat exploratory, and I would like to see the data on potency and continence before we really say this is definitively the way to do the operation. The other way people are exploring doing the operation is using the Da Vinci robot. We're starting to do some of these here. Just did one on Friday, in fact. The Da Vinci robot, again, this is just a way to do the operation laparoscopically. It's done by the surgeon actually sitting in a console away from the operating table, manipulating the robotic arms. These are essentially robotic arms that are through the laparoscopic port. So it's just another way of doing laparoscopy. But the advantage is that when you're doing it from the console, you have 3D vision, you have maybe slightly more magnification. Again, is this going to be better? Well, it's too early to tell. This was first described back in 2002. Again, we have zero data that tells us about potency or continence. I suspect that eventually it'll be as good, but it's being, to some extent I say buyer beware. This is being sold a lot. I gave a talk comparing this technique to the open operation. When I searched for actual data on the Da Vinci robot, I encountered one article in the literature, as opposed to several thousand with the open radical prostatectomy. When I searched, I just for fun did a Google search of robotic prostatectomy, and I got 600 hits. So it's being advertised heavily out there. Do we have data that says it's as good? We don't. Do we have data that says it's better? Certainly not. But again, stay tuned. We'll see what happens with this operation. It's a very intriguing way to approach the operation, and perhaps it's going to be as good and avoid the incision. They have a tough row to hoe to try and make it better than the open operation, but at the very least it might avoid the incision. In the long run, we'll see how it evolves. The definitive thing is going to do a real randomized clinical trial. That's in the offing in several years from now. Now, what about radiation therapy? Radiation therapy comes in several different forms nowadays. Brachytherapy is very popular right now. Brachytherapy has been used for a number of years, but really things came together in about 1990 when people became more facile with the use of ultrasound to guide the placement of the seeds. So what it is this is a man up in stirrups. He's shown from the side, and you can see the ultrasound probe in the rectum guiding where the seeds are placed, and we put little needles up through the perineum and drop little seeds, radioactive seeds, throughout the entire prostate gland. When you're finished, this is what it looks like on an X-ray. You can see all the little seeds deposited all throughout the prostate. You have to treat the entire prostate gland. We know that from our years of doing radical prostatectomies, and the reason that is the case is that if you look in a prostate gland that's removed at surgery, the cancer isn't just where the biopsy told you it was. In fact, you will find on average about 5 to 7 separate sites of cancer spread throughout the prostate gland. So when you treat with seeds or any type of therapy, you have to treat the entire gland. You can't just remove part of it or radiate part of it. You treat everything. The advantage of brachytherapy, it's an in and out procedure. You come in, you get your seeds in, and you go home. It can cause some urinary irritation, sometimes to a dramatic degree. It can be technically demanding and quite challenging, and the reason for that is when you're putting the seeds in, you distort the prostate gland because swelling happens. So you have to be very careful about how you place those seeds. There is a chance of leaving cold spots, that is, leaving areas in the prostate that get no radiation because you didn't quite see it very well on the ultrasound at the time of the procedure. But that being said, it looks like a very reasonable way of treating prostate cancer and a very popular one, as I mentioned, nowadays. I'll talk about data related to it in just a second. External beam radiation therapy. This is radiation aimed from the outside. This is a linear accelerator in which from several different angles, radiation is aimed at the prostate gland. We used to do it from 2 angles, and that led to real problems with skin burning and things like that. Nowadays, we use the latest technology here. We usually we're lucky because we live next door to Varian, so we always have the latest, greatest in radiation therapy here. The latest is intensity modulated radiotherapy, in which the location of the prostate is found very carefully using CT scan and MRI prior to treatment planning. And then the beam is directed from many different angles to concentrate the beam on the prostate gland, increase the dose you can give to the prostate, and the dose is very, very important for increasing cures. Higher doses, better cure rates. Lower the dose that happens, lower the radiation that happens to surrounding tissues, so potentially decrease complication rates. It, again, is a very well-established way of treating prostate cancer and works very well. How well do they work? This is a study that was done out of Harvard and the University of Pennsylvania, in which they looked at surgery, radical prostatectomy, external beam radiation therapy in green, and then seeds, and then adding hormonal therapy. The bottom line is, this is what's called a Kaplan-Meier curve. The higher the curve, the better, okay? So if you look with low-risk, low-grade disease over here on the left-hand side, all the curves are pretty high and they're more or less superimposed. A statistician couldn't tell the difference between them. For men with low-grade disease, low-risk disease, all therapies look like they work pretty darn well. For men with higher-risk disease, and that would be defined by either a high PSA or a high Gleason score, a high grade. The grade is a measure of aggressiveness. It looks like the men who get seeds don't do quite as well. More of them have a recurrence, so that curve drops down to the bottom here fairly quickly, where surgery and external beam radiation therapy remain doing pretty well. So it may be that men with high-grade disease, seeds alone is not the way to go. Why might that be? If I were to speculate, it would be because it is more critical to really treat the cancer entirely in men with high-grade disease. And with seeds, as I mentioned, you have a potential of missing spots, of having cold spots where you didn't get a seed even though you intended to, just because of the swelling and distortion that happens at the time of the procedure. So I think that is probably the reason you see the difference with the seeds. So again, this is somewhat an evolution. And at the very least, when I counsel patients, I tell them just to be aware of this data, that if they have higher grade disease, do not think about having seeds alone. The CyberKnife is a new technology, again developed largely at Stanford by a neurosurgeon named John Adler, who's this CyberKnife is actually on a robotic arm that rotates at many different angles, directs the beam. It's like something out of Star Wars. It's incredible. The thing will rotate to different angles, and what it does, which is different from other types of radiation, is it actually compensates for exactly where the prostate gland is moment to moment. So the beam then is aiming very, very accurately. And the reason that's important is that with external beam radiation therapy, you don't have any real-time way of changing where you're aiming. You plan the treatment at the beginning, you stick with that treatment all through it. All through the course, you aim at try and aim at the same spot. But we know that the prostate, just like other organs in our body, can shift around depending on whether you have, if you have stool in the rectum, it can change the position of the prostate gland. The CyberKnife compensates for that because there are little gold seeds that we put in the prostate and allows it to aim very, very precisely where the prostate is. This is an experimental protocol being run by Chris King in the Department of Radiation Oncology. He's treated a couple dozen patients at this point. The other advantage with the CyberKnife is that the treatment course is much more condensed and shorter. With external beam radiation therapy, it's on average about 8 weeks. The CyberKnife is shorter. I don't have exact numbers for you. But they've been very happy with this, and again, relatively low side effects, similar to what we see with surgery and radiation therapy. To kind of summarize, when thinking about treatment, there are a variety of factors we take into account. And those factors we have to balance, and like I said, it is a difficult balance sometimes to make. But the first and foremost is the person who has the tumor, so-called host. So the age of the patient, a man who is let's say, 83 and comes in with a small amount of low-grade cancer is maybe best served by watchful waiting, as opposed to a man who is 50 and comes in with a, let's say, a moderate grade prostate cancer, may be better served with surgery. Whether or not the patient has other health conditions that might either make it dangerous to operate on them, let's say they have a heart condition that makes an anesthetic dangerous, and also what the patient's values are. You know, there are some patients who just do not want to go within 100 yards of a scalpel. Other patients have friends or relatives who had a bad experience with radiation therapy, don't want radiation therapy. So obviously that has to be taken into account. Also the characteristics and qualities of the tumor, the grade, the stage of the cancer, what we feel on rectal exam, the PSA level or the change in PSA over time, what we find on the biopsy, all goes into the decision process. Remember what I showed you earlier, men with high-grade disease probably should not be treated with seeds alone. The risks of the treatment. As Milton Friedman has said, there's no such thing as a free lunch. There are risks to every one of these treatments. The main risks are that people talk about in the long run are risks of urinary bother and risks of sexual dysfunction. They can happen with any of the treatments, and I'll be honest with you, the more I look at the treatments, the more similar these risks look. And finally, the thing we take into account is the potential benefit of the treatment. We do believe we actually are making a difference in these treatments by treating early localized cancer, finding them early, and treating them earlier. We're making an impact. And actually, there are clinical trials that are in process to determine that is the case. But at the very least, we know we are from the Scandinavian trial that shows surgery versus watchful waiting does make an impact in terms of cancer survival and development of metastases. So we definitely derive benefit from treatment. The other clue for that is, and this is my last slide. This is an interesting slide. Again, it's somewhat speculative, but if you look at the rate of dying of prostate cancer, it's been slowly creeping up for a number of years now. And this is just showing a small cone-down view of basically from 1970 to the mid-1990s. And what you see is that that curve was gradually going up and up and up. It even took a little bump in about 1990. Then thereafter began to trail off. What many of us believe is that that trailing off has to do with us screening very aggressively for prostate cancer using PSA screening and also digital rectal examination, and also treating those patients who have the disease aggressively with surgery or radiation therapy. If you look at European countries in which screening has not been used, England is a classic example, but also the Scandinavian countries, that curve has continued to go up and up and up, completely linear. There is no drop-off like that we see in the United States. And in fact, these numbers are a little bit old now. The last numbers I saw, the latest numbers out of the American Cancer Society show that since 1992, the death rate from prostate cancer has dropped 26%. And again, I think that is largely due to screening efforts and aggressive treatment efforts that began really in the 1980s. First of all, with the perfection of the operation, or the improvement of the operation, I should say, but also with aggressive screening that started right around 1987. So we have a long way to go, but we are definitely making an impact on this disease. And in fact, I think as research continues to improve and we continue to gain more insights, the outlook continues to look better and better. And at this point, I'll be happy to take any questions. Thank you. The question is, are these treatments that I reviewed now just for cancer in the prostate? And by and large, they are. So surgery, we reserve it for men who just have cancer in the prostate. Remember, that's 95+% of men diagnosed nowadays. Less than 5% of men come with advanced disease. So too with radiation. Now that being said, there are some men who come in with cancer that's spread, let's say, to the bone and is causing them some problems there, where you can radiate those sites and take care of the pain, for instance. But by and large, the treatments I discussed today are for localized prostate cancer. So the question is, if it's spread to the lymph nodes, how do you treat it? Somewhat controversial, but probably hormonal therapy is a reasonable thing to think about. Some of those men who, let's say, I've operated on, they have a teeny amount of cancer in their lymph nodes. If you follow those men long term, about 15% of them are cured. But there is a study that indicates that potentially hormonal therapy can prolong men's lives if they have cancer in the lymph nodes. Now people are starting to look at various forms of chemotherapy also. The question was related to someone who presents with a very high PSA but still treated with hormonal therapy and radiation therapy, and that in those cases absolutely things can be effective. Remember what I told you about Charles Huggins? Just with hormonal therapy alone patients can respond for 10 plus years even with very advanced disease. So we have in hand very effective treatments for prostate cancer at all stages. The question was, what about a man who has a normal PSA, who is in their 60s, and father and brother both had prostate cancer? Somewhat controversial, but not entirely. I think it is appropriate. What the standard of care is just to screen that man very actively. So at least yearly PSA and digital rectal examination to keep a close eye out for any signs of prostate cancer. There are some people debating about whether we should lower the threshold for PSA down to 2.5 instead of 4. It's a major shooting match. No one showed that results in higher curability of the disease, but that's something in the back of their mind. The other thing that I keep in mind in looking at patients is, what is the PSA doing over time? So I've had patients who've had very low PSAs, but they're high risk, and let's say their PSA is at 1 and their PSA the next year is up at 2. Or 2.5. A change of PSA in that degree over a fairly short time period, and by that I mean over a year, might merit a biopsy. So I have a low threshold for biopsying that patient, even in the normal PSA ranges, if there is a change in PSA over time, what we call, in the business, what we call a PSA velocity. Question is, a case where the PSA can be way out of whack. So this was an instance of a gentleman whose PSA was at 13 and then went back down to 3. This gets to the vagaries of PSA. And PSA, maybe you've seen in the popular press lately, has taken a lot of heat. The bottom line is that PSA is merely a measure of something going on in the prostate gland. Okay? PSA stands for prostate-specific antigen. It's a protein made only by the prostate gland. Now, a variety of things can make the PSA go up. Enlargement of the prostate, chief culprit. Okay, probably 70% of the time the PSA is elevated, it's due to the fact that our prostate's just enlarged. Infection in the prostate or inflammation in the prostate can make your PSA go up. I've seen PSAs go to 100 because of an infection in the prostate. Or prostate cancer, or I don't know. I mean, sometimes there are reasons that the PSA bounces up that I have no good explanation for. The bottom line is, if a man is cruising along with a perfectly acceptable PSA, let's say it's 2.5 or 3 in this instance, and all of a sudden, you've checked it 1 year and the next year it's 13, the first thing you should do is repeat that PSA. Because there can be cases where the PSA will fluctuate. We know, for instance, that if I take a man and measure his PSA every single day over 2 weeks, it'll fluctuate by 30%. And sometimes it can fluctuate dramatically. I've seen many a patient with that exact scenario. PSA goes up to 13 and then goes back down. Just saw one today in my clinic. So it can happen. You have to be very careful with PSA. The question is the frequency of urination related to the prostate? The answer is absolutely it is. An enlarged prostate increases the frequency of urination in many men. Not all of them, but with enlargement, many men have change in their urination. Slow stream, starting to get up at night to urinate, frequent urination during the day, maybe some urgency, maybe a little dribbling. All of these are signs of an enlarged prostate gland. And remember, 75% of us get an enlarged prostate gland. About 25% of us need to be treated for it. It's almost hard to even call it a disease. It's almost a normal part of aging. It's so common. The question is, will bicycling affect the PSA? I don't know how to answer that. There are certainly reports of it elevating the PSA. But no one has studied it intensively enough for me to say that it elevates the PSA on average 3 points. I don't know. I honestly don't know. Could it happen? Sure, it is theoretically possible. Been reported in the literature. But I wouldn't glibly write off an elevation of PSA to strictly bicycle riding. Just be careful. The question is, what about enlargement of the prostate gland? As I just mentioned, enlargement of the prostate gland can cause urinary symptoms. Frequent urination, a lot of trips to the bathroom, getting up a lot at night. Are there ways to treat that? Absolutely there are. Now, the mainstay up to about, let's say, 15 years ago was to operate on men. What's called a TURP, transurethral resection of the prostate gland. We go in through a telescope and hollow out the inside of the prostate. Sometimes referred to as a roto-rooter job. Now that being said, that operation has diminished quite a bit, and the reason it has is because we've developed medical therapies that are pretty effective, reasonably effective for it. The two mainstays of medical therapy are, first of all, a set of drugs called alpha blockers. Alpha blockers are drugs that relax the muscle in the prostate gland, open it up, and make urination better. Those drugs are really terrific for helping men who have a lot of frequent urination. Okay? They don't help 100% by any means, but many, many men are helped by these drugs and helped fairly dramatically. The second set of drugs are the one I alluded to in my talk, the drug called finasteride. It's a class of drugs that are called 5-alpha reductase inhibitors, and that's a tongue twister you don't need to worry about. The bottom line is, what they do is to some degree block the male hormone testosterone in the prostate. Now the prostate, like all of our reproductive tissues, depends on the male hormone testosterone to grow and live. If you block it to some degree, the prostate gland will shrink, and it shrinks on average about 1/3 of its size when you put men on finasteride or Proscar. There are other drugs in that class also. So those are two things. The advantage of the alpha blocker is that it helps with the frequency and urgency. The disadvantage is some men develop a little dizziness from them because these drugs are also used to treat high blood pressure. So some men have some dizziness. The Proscar, the advantage, tremendously well-tolerated drug. Very few side effects. Disadvantage, takes 6 months to a year to work. The question is, for men who have advanced prostate cancer, either that's come back after surgery or they walked in the door with advanced prostate cancer, what about castration versus using the medicines? The medicines, like I mentioned before, Lupron, which is a shot, and plus or minus the pills, Casodex and flutamide. Actually, there's really probably no difference between castration and the drugs. They have the same side effects. They also have the same spectrum of effectiveness. It looks like they are equally effective. They both drop your testosterone to comparable levels. The advantage of the drug is that you avoid the operation and you avoid the cosmetic effects of having your testicles not there. The question is how to treat men who've had a PSA come back. And let's take the simplest scenario, PSA that comes back after surgery. Do you give hormonal therapy for a brief time or continuously and so on? Huge controversy right now. Huge controversy. And the treatments range from some physicians who think that you should give hormonal therapy to those men immediately, all the way to the other end where some physicians, including my old boss, Pat Walsh, who's a pretty smart guy when it comes to prostate cancer, he won't treat his patients with hormonal therapy, simply watches them. And then there's the intermediate ground in which they give hormonal therapy just for short bursts, which is called intermittent hormonal therapy. Let's discuss both ends of that. People have looked at giving hormonal therapy early versus giving it late. It's confusing. And what I mean by that is, let's say a man has surgery, PSA comes back, and you treat him right away, versus a patient who you followed for years and years and years until something shows up in the bone, let's say. Prostate cancer shows up in the bone. That would be late hormonal therapy. There have been studies that have compared the two of those. Some studies show there's no difference in the length of survival. Hormonal therapy works terrific, and it works terrific whether you start it early or you start it late. Okay? The one thing that is clear is that if you start hormonal therapy earlier, you can delay the time it takes until cancer shows up in the bone. But once it shows up in the bone, it doesn't necessarily mean you're on God's green earth for any longer. Okay? So the survival times look about the same. Some studies have shown a slight difference. It's on the order of maybe a few months to the advantage of starting hormonal therapy early. We honestly don't know. And once again, it comes down to a review of all that data and a heart-to-heart discussion with the patient about what their objectives are. If a man has had surgery and has a recurrence of PSA afterwards, and you put him on hormonal therapy, you are probably committing him to a decade or more of hormonal therapy with the attendant side effects of hormonal therapy. You have to bear that in mind, and that definitely affects quality of life. Okay? Now, the other question that you raised is, what about intermittent hormonal therapy? And what that is the shots have given us a chance now where, in the olden days, if we treated with hormonal therapy, we took out the testicles, that was it, you're on hormonal therapy. There's no putting them back. Whereas now we can give the drug and then give people little vacations. So you give them the drug for varying lengths of time. Some people say 3 months, some people say 6 months, some people say a year. No one knows which is the proper length of time to give the drugs, and then stop them for a time. And the advantage is you get a little break, so you're free from the side effects of hormonal therapy for varying lengths of time. Some patients I've had on intermittent hormonal therapy get 2 years off in between their treatments. Some it's much shorter, the durations between. Does that mean, the question that's unanswered is intermittent hormonal therapy, that is giving it every once in a while, as effective as putting a patient on and leaving them on? Clinical trials are designed now that are ongoing to answer that question. I can't answer it today. I'll tell you that intermittent hormonal therapy, at the very least, is experimental at this point. We don't know the answer, whether it's as good. Question is, patient comes in, we get a biopsy, there's some funny-looking cells, let's say, that might be cancer, but we're not sure. On the first biopsy, the right thing to do is get another biopsy. So that is absolutely the right thing to do. The next biopsy, let's say the next biopsy comes up clear. Standard of care usually is to watch patients at that point, have a low threshold for biopsying them again if the PSA bumps, or maybe you wait just a year and just biopsy them anyway, just because you're worried about that patient because of the funny-looking cells of the first go-around. What I suggest is, and this will vary from patient to patient and from pathologist to pathologist, but if you've had a biopsy that there's any question on, many times it's a good idea to get a second opinion on the biopsies, have another pathologist look at the biopsies. I can't say that's universal for every patient, but many times a second opinion is good advice, and that's what many reference pathologists and people doing a lot of prostate cancer will tell you. Should we continue to screen a man who is, let's say, 85 years old? I don't know the answer to that. What I can tell you is there's a clever guy named Peter Albertson who's at the University of Connecticut, in which he looked at men who had been diagnosed with prostate cancer in the 1960s and 1970s and had no treatment. Back then, we were somewhat nihilistic about prostate cancer and thought it was that all men had disease you died with rather than from. The bottom line is, if you follow those men, some of those men were followed, some of those men were operated on. If you look 10 to 15 years later, for the men who were above the age of 75, treating them didn't look like it really prolonged their life a whole lot. Why? Because probably something else is going to get you after the age of 75, at least if you're in the decade of the 1960s and 1970s. Now, people are living longer now, so maybe that number has moved up a little bit. We're playing a numbers game, and I have occasionally patients, a 75-year-old patient is brought in to see me by his parents. Well, that guy I'm probably going to, think about treating fairly aggressively. Okay. The question is, what are the causes of frequent urination? Frequent urination is, before surgery, the causes are an enlarged prostate usually. Afterwards, the causes of frequent urination are usually one of two things. Either there is scar tissue where the urethra and prostate have joined together, and that narrows things off. It's like having an enlarged prostate. The urethra is pinched off. So scar tissue is one possibility. Possibility number two, your bladder, the bladder is just overactive. Overactive bladder happens as we get older, happens in both men and women. Remember, women don't have a prostate gland blocking them off. They still can get frequent urination just due to the fact that with aging, the bladder gets less compliant and gets a little bit more twitchy. So it could be one of those two things. It's either bladder or overactive bladder or some scar tissue. Cryosurgery, there's a question about cryosurgery is basically freezing the prostate gland. It was tried in the 1960s with somewhat disastrous results. Now they've refined the technology quite a bit, and people are out there advocating cryosurgery. I have some quibbles with cryosurgery myself. They did quite a bit of it up at UCSF, and we're Dr. Presti here. He was up at UCSF during that time. He's quite negative on it, and the reason that many of us are negative about it are, number one, impotence rates are 95% or more. So when you freeze the prostate, you freeze those little nerves alongside the prostate. There's really no way to save freezing them, so many men are left impotent. The second problem is that you can freeze the sphincter. Remember, the sphincter is the muscle that wraps around the urethra that holds your urine in afterwards. And that can lead to men being incontinent. In the early series, 1/3 of men were incontinent. Now I think it's better with the slightly better technology as people have gotten better. The third problem with cryotherapy, fairly high recurrence rates. Cancer can come back. The fourth problem with it is When you freeze the prostate gland, you're not taking any of that tissue out. It's just sitting in there, basically dead tissue, frozen dead tissue inside the prostate. And men can develop all kinds of complications as they slough that tissue and bleed. And I've seen a man who developed a huge stone around that tissue. It can be really a problem. So it's, again, as Milton Friedman said, no such thing as a free lunch. There are definitely side effects to cryotherapy. And I think you're better served by either one of the varieties of surgery or one of the varieties of radiation therapy. That's my personal opinion. The question is, can venereal diseases early in life predispose to prostate cancer later in life, or any type of infection? This is really a big area of interest right now. The bottom line is this: if you pool a whole bunch of studies of huge populations of men who have had at some point in their life gonorrhea versus those who didn't, or syphilis, name your venereal disease, it doesn't matter which one, they have perhaps about a 1.4-fold higher risk of developing prostate cancer later in life. Now, that degree of risk is such that many statisticians will tell you, maybe, maybe not. But it does lead to the intriguing notion that inflammation in the prostate gland, probably from an infection, predisposes to later getting cancer. Now, we know in other diseases, lung cancer, colon cancer, stomach cancer, that the presence of inflammation will predispose to later developing a cancer in those regions. What is believed that happens is that with inflammation, what inflammation is the white cells release all these things called oxygen-free radicals. And oxygen-free radicals can damage the DNA, cause mutations, and ultimately may lead to cancer. And that's kind of the going model. It's not that simple, though, because inflammation does a variety of other things. But it is possible, and this is really a hot theory in prostate cancer right now, that the inflammation in the prostate contributes to prostate cancer. So you might be onto something here. That might also be contributing to the differences between the races, or contributing to prostate cancer in general, is inflammation. The question is, does Viagra, we don't know that Viagra predisposes to prostate cancer. The only thing I can say relevant, obtusely relevant to that, is if you look at men, the frequency with which men at a young age ejaculate and the risk of prostate cancer later in life, there are a couple studies that show more ejaculation, lower risk of prostate cancer. The question was vitamin E and selenium, what exact dose, how long do you take it, and things like that. We don't know enough about it yet. That's what that SELECT trial is all about. That's set up to answer that question. The dose that's being given, I think, is somewhere around 400 international units a day of vitamin E. That's the lowest dose. Remember, there are studies that just came out recently out of Johns Hopkins suggesting that vitamin E might actually predispose to cardiac disease, so just bear that in mind before you start throwing down the vitamin E. Very high doses of vitamin E are probably not a good thing. They can predispose to strokes and bleeding and things like that. In terms of selenium, the going dose out there is for selenized yeast about 200 micrograms. Again, in this area, we probably don't need to take it. If you live in the Bay Area, we get a ton of selenium in our diet. So I'm not strongly encouraging my patients to take it. I personally am not taking it, nor am I taking vitamin E, in case anyone's wondering. I'll go on record as saying that.
The preceding program was brought to you by Stanford on iTunes U and is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at itunes.stanford.edu.